am excited to be here discussing equitable distributions of vaccines and just myself and my colleagues' approach to distributing COVID-19 vaccines. So I have this presentation. It's entitled Let's Talk Equity. So some objectives of these presentations include describing a three-tiered model to increase COVID-19 vaccine uptake within minoritized communities, also explaining the importance of culturally representative clinicians in overcoming vaccine hesitancy within minoritized communities, and then finally identifying the appropriate stakeholders required for the successful completion of community COVID-19 vaccination clinics. So at Loma Linda University, where it is that I practice, we developed a three-tiered approach for creating equitable COVID-19 vaccination access. Those tiers included, first and foremost, the engagement of faith leaders, ultimately the delivery of COVID-19 vaccination education from a culturally representative healthcare professional or myself, and then finally, low barrier community vaccination clinics held right there within targeted minoritized communities. So, to provide a bit of background, the engagement of faith leaders looked a bit like talking to different pastors, mostly those that were Black or Latino, Latinx, um, in regard to their racial and ethnic background, and describing just the COVID-19 vaccination process and working hard to make them stakeholders in the education because one, they're very intimately acquainted to the burden of COVID-19, especially amongst their parishioners and community. So they are very much invested in overcoming the virus. In San Bernardino County, particularly, we have two organizations, the Inland Empire of Concerned African American Churches, or ICAC, when the congregations organized for prophetic engagement, or COPE. Comprised within these groups are 20 churches, including 20 pastors. Therefore, we were able to have a large span of faith leaders to then engage in this educational process. So while it did take a bit of convincing on our behalf, the pastors have just been so integral in being able to get this information out in regard to the COVID-19 vaccinations, motivating their parishioners and church members to get vaccinated, as well as organizing church-wide sign-up lists, creating platforms for us to distribute information in regards to the vaccines and in regard to the clinics that we hope to have. And then they also have disseminated sign-up sheets and pop-up tents, chairs, and tables as we had the vaccination clinics right there at the homes of those churches included within those groups. Also, we included the delivery of COVID-19 vaccination education from a Black pharmacist or myself with infectious disease training. So the discrimination and mistreatment of Black individuals is very much heavily ingrained in the consciousness of the Black community and in the fabric of the United States identity. So with that, we knew that overcoming the mistrust of the Black community and other racial and ethnic groups would be very much important for us to do, and it will require cultural representation that needed to be a major key. We knew that those groups needed to know that they were represented, that they were cared for, and that someone that looked like them was behind the scenes and on the scene when they went to get vaccinated. So with that being said, I myself made myself a trusted individual within the community that we went to vaccinate. I participated in COVID-19 vaccine summits that we would have utilized to deliver information in regards to the vaccines. But additionally, I would also go to different churches comprised of those church groups and give information in regard to the COVID-19 vaccines. But I made sure to let those individuals of those churches know that I would be on the scene at these vaccination clinics. That was important to them because they wanted to know that they were in fact not receiving placebo, as we know that is something that's happened in the past with minoritized groups, really talking about the Tuskegee experiment with Black individuals. So making sure that their fears were being adequately addressed is a really big point. And it's also the reason why we need to be sure that we make cultural representation very much a necessity across these equitable vaccination delivery methods. We also created a low barrier vaccination clinic. So with that being said, there are several barriers to vaccination. Those barriers can include access, So actually having the COVID-19 vaccines there within the community, easy to reach. They can also include transportation, getting there to the vaccine clinics. And then finally, it can include internet, computer access. And then we also know that we have that the large social media divide or internet access divide, the digital divide that's very much represented amongst minoritized groups. So, with that being said, at Loma Linda, we created a paper-based vaccination sign up form or registration form. So here on this consent form, we have all the information necessary for conducting these vaccination clinics, everything that we would have to upload into the system. But we take away that extra barrier of having to find a computer or having to have internet access to sign up. And then we also create that ease of being able to have that form there to be able to sit next to your friend or someone that you know within your community getting vaccinated. You have that opportunity to complete the form, and if you're a bit delayed or if you have some additional questions that you want to ask, you have that opportunity there because all you have to do is just fill out that form, and once you're ready, you can go ahead and be vaccinated. We also have that pop-up clinic or the remote site clinic. I go back and forth with the mobile clinic, pop-up clinic, remote site clinic verbiage, all very much the same. So we put that clinic right there in the Black community, and we make sure that we create an ease of access to these clinics. So it's right there at that neighborhood church that you may see right there, where it's easy for those individuals to get to the clinics and not be burdened by having to acquire transportation to receive the vaccines. I also like to make sure that I go through a clinic, kind of like a workflow, or how are these clinics set up? Because it's one thing to say that we have these low barrier clinics, but it's another to give everyone a kind of an idea of how we go about aligning these clinics. So our clinics are conducted either indoors or outdoors. So the format is very much consistent, irrespective of location. So whether it be indoor or outdoor, we have a registration area. So at that registration area, we can include community health workers. We can include church personnel. It's not necessary that we have to have clinical personnel that work here at this registration area, but they make sure that that paper-based form that I showed you all is filled out to its completion. In the event that there are any questions, any errors, they'll call over the clinical leads to take a look at that form. However, once that form is completed, they then send the individual right there to section 3, which we see in green, and that's kind of our waiting area. In that waiting area, we have someone that acts as crowd control that then sends these individuals to go to the vaccination areas. So we have about 5 to 6 vaccination tables, and we split these tables into two. So we end up with about 6 to 10 individuals that act as vaccinators. It's dependent upon the amount of people that we plan to vaccinate at each clinic. And then we have a vaccine draw area, which takes place indoors. So, irrespective of where that clinic is, if it's outdoors, or we have a small place indoors where we draw that vaccine so that we can make sure that it's not affected by the climate. We have a licensed pharmacist that manages the vaccine draw. However, we do include professional students and non clinical faculty that assist in that vaccine draw. We also have a checkout station. At that checkout station, we make sure that individuals receive information in regard to what vaccine they've received. And we also have a physician or a nurse practitioner. Sometimes we have a pharmacist over there in that area for observation so that they can ensure that nothing goes left when individuals receive these vaccines. And in the event that they do, they are equipped to go ahead and resolve that issue. So when we talk about clinics, we have to make sure that we give just a bit of context into the necessary stakeholders. I want everyone to be able to kind of take this approach that I'm explaining and go ahead and use this to go ahead and develop your own remote site clinics. So first and foremost, important stakeholders include faith leaders. So as I stated, that was the first point in our tiered approach. We utilize faith leaders, that being Black faith leaders, Latino, Latinx faith leaders, as we really wanted to target those minoritized communities. They have just been so integral in ensuring that we have been able to have a successful vaccination process, so much so that we published our methods in the Lancet journal. And when we published our methods, we made sure to include the faith leaders, the Black faith leaders that assisted us in our initial clinic in that publication because they have just been so integral to our process. And it's so often that we write about the community, however, we don't include them in those writings. So we were able to do that. And I once again cannot reinforce how important they are to have them on board for these community vaccination efforts. Additionally, our clinics are majority pharmacist run. So we include pharmacists as vaccinators. We include pharmacists as those that serve in that vaccine draw area. They also serve as experts on the ground there. So when individuals do have questions about that vaccine, they're able to answer those questions and reassure them and inform them of the vaccination process. We also have additional pharmacy staff. So we have professional students. Our pharmacy students have just been so integral to making sure that these vaccination processes go as planned. They have just been so engaged, and I'm so impressed by their involvement here in these clinics. We also have pharmacy technicians that come on board and they serve as vaccinators, as they are able to do that in California. We have medical professionals. So our vaccination clinics are very much interdisciplinary. So we have physicians, we have nurses, dentists, respiratory therapists. They all come on board. They serve as preceptors, ensuring that our students have correct technique. They serve in that checkout area, as I previously stated. And they also vaccinate themselves or come in that vaccination draw area. So it's been very much a multidisciplinary effort here. We also have community health workers and church volunteers. These community health workers have been so important to our vaccination process because they know their community well. They know us where they can tell us where to go. What are these areas that need access to these vaccines? And currently, we've begun to go right into the community and actually knock on doors to go ahead and further make this an equitable process and deliver these vaccines. So these community health workers have really been our eyes on the ground. So they've been great for these clinics, as well as church volunteers. As I stated with that registration process, we often have our church volunteers work there, and it's important when you have individuals from the community come there. They're able to see, Sister Johnson or Ms. Robinson, individuals that they know from within the community, which is reassuring when they come there to get vaccinated. We include administration personnel. My administration it's pretty much my right hand woman. So she very much makes sure that we have everything that we need to go ahead and make sure that the clinics run the way that they need to. We also have our supply chain management, who ensures that we have all necessary supplies to conduct all of these clinics. I also believe that it's important that we talk about just the professional students here in these clinics, because it's one thing to talk about having these community clinics and their importance, but it's another thing to consider the longevity and just what longevity means and how we need to train our emerging clinicians to have equitable minds and to be empathetic. So I can speak for myself as a student. I didn't learn much about illnesses in terms of social determinant of health inequities. So the students actually being able to see these inequities on the ground really just contributes to how it is they will consider things and think about approaches to delivering their own equitable processes when they're practicing. So these volunteer opportunities just provide them with those very, very tangible experiences. Of course, it doesn't make sense if you don't have tangible and outcomes that you can speak to. So we've done a number of vaccination clinics within the Black community, which is what I'll talk about here. So we've done several Moderna vaccination clinics, first and second dose. We've done a Johnson and Johnson vaccine clinic as well as more recently Pfizer vaccination clinic. So I do have information here from our first vaccine clinic because I think that it really helps to put everything into context. So in February, prior to us going into these clinics, so from late December to mid February, we have vaccinated about 17,000 or a bit over 17,000 individuals. Of those 17,000 individuals, 579 or 3% identified as Black. This was in our mass vaccination clinic effort that we had at Loma Linda University. To provide a bit of context, Loma Linda University had the largest vaccination site in San Bernardino County. So then when we move ahead to our mobile vaccination or our community vaccination effort. This was a 1 day clinic. We vaccinated 420 individuals. However, 351 of them, or 83.5%, were identified as Black. So we saw an overrepresentation of this previously underrepresented group, very necessary overrepresentation. And this was due to very concerted efforts to increase vaccinations amongst this minoritized group. So we also did see, following this vaccination effort, the week following, we saw a 0.6% increase in Black vaccinees at the mass vaccination site. So of course, this can be by happenstance, but we like to think that it's likely due to the fact that we were able to talk about our vaccine effort and to really provide awareness in regard to our mass vaccination effort as well. So we also want to know, is there reproducibility? Can we take these vaccine clinics that we've done in the Black community, which is what I really talked about here, can we go ahead and translate that to other minoritized groups? So I talked about this briefly, but we are also utilizing our model within the Latino Latinx community, which has once again been underrepresented, as we all know, with amongst COVID-19 vaccinations, but very much overrepresented amongst COVID-19 deaths. So these clinics include, we've done Moderna vaccination clinics, Johnson and Johnson, as well as Pfizer more recently. I would really like to focus in on our first Moderna vaccine clinic. So in our first dose clinic, we vaccinated 258 primarily Latinx individuals. So when we looked at that second dose vaccination clinic, we had a 97% return rate, meaning that 253 individuals returned back here to this remote site, pop-up, mobile clinic, whichever way you want to state that. They returned right back there at that vaccination clinic to go ahead and get vaccinated. So with that being said, I just want to state that this is just the importance of having an equitable distribution and just our contributions to making sure that we are able to, as I like to state making equity a verb.
Thank you so much, Dr. Abdul Mutakabir, for that nice brief overview of what you all are able to accomplish at I always want to say LLIU, but LLU, right? Forgive me. Up in California, that's definitely amazing. We want to continue part of our panel here with some other folks, and I'm going to introduce them and briefly, and they'll tell you a little bit more about their experiences at their different sites. So the first person, again, Dr. Abdul Mutakabir, will be discussing some more about her clinic that she's been able to lead. We also have Dr. Sue and Dr. Tariff. So my first question to the group here is, if you want to tell us a little bit more, just briefly, about some of your mobile clinic efforts you've had at your different places. And of course, tell us a little more about where you are at, what part of the country you're from.
So I'm Colleen Tariff. I'm a pharmacist. I practice in Eastern Washington, and my experience actually is before COVID and during COVID, and hopefully will continue afterwards as we're needed. I have experience in both mass vaccination clinics and mobile kind of community, you go where you need to go, clinics related to flu vaccinations, with MMR outbreaks, even going into community jails and vaccinating for a hepatitis A outbreak. And also I've done drive-through clinics and the like. And I have a feeling many of in our audience have been involved in a variety of experiences over the years and decades, or maybe for the first time, as COVID pandemic has mobilized them as volunteers in getting involved. And also worked in community centers and college campuses. But I will say just two quick examples of some recent COVID-related experiences that have been my favorite so far. Spokane, Eastern Washington is not very racially or ethnically diverse, but we do have the second largest Marshallese community in the country. And one of the mobile clinics I was involved in was partnering with PICA, which is Pacific Islander Community Association of Eastern Washington. And what they did is they partnered with a school district. Then they also partnered with our health district for one clinic, and then switched partners just logistically with a community health clinic as well. But they dovetailed it into an event where they also had a food drive and gave out community flyers with different events, and came in as part of the medical team and overseeing the observation and helping vaccinate as needed. And I will say it's important that there, as appropriate, there's interpreters there, and interpreters who have experience with or have some medical background, because this is, I think, a different type of interpretation. And also, I agree 100% with the importance of faith leaders, and also community leaders as well. So just a quick experience of when we were having people sit in their cars for their observation period. One of the community leaders, she was known by everyone, she was helping kind of distract and keep everyone relaxed and casual conversation, while someone medical was also just observing for any sort of complications or side effects. And I will say, the other thing is to ask some of those community leaders, as you're doing your job, side effect monitoring, counseling, getting ideas of what's culturally sensitive, because as pharmacists, we think we need to tell people about side effects in a certain way, but maybe that needs to be changed depending on the groups we're vaccinating. The second was with our Martin Luther King Center, which serves a big BIPOC population, and they also did scheduled vaccines, but were flexible to have walk-ups as well, which I think is important, to stay flexible. And they had people assisting every step of the way, including IT personnel who could help with the clinic and their computer issues, but also if members of the community had issues with access, to talk to them about what their needs are and ways around kind of that barrier. So that's some recent experience I've had with COVID clinics in the community.
Thank you, Colleen. How about you, Christy?
Hi, everyone. I'm Christy Sue, and I'm calling in today down from the South, from Houston, Texas. So the clinic I work at is different from maybe a little bit of what Colleen said. So the experience that I'll be sharing today is from the days that I've spent staffing an on-site hospital clinic for the community for about the past 7 months now, which has definitely been interesting despite being at a hospital. We don't have any formal community collaborations, but rather from those people earlier back when appointments were required, now we're taking walk-ins as well, that would actually come in and drop off business cards so that we could stay connected with larger companies or even other communities in the event that especially we have extra doses at the end of the day. So we don't formally service homebound patients. That was another area that had been brought up, but we do and have made arrangements with outside facilities to help arrange transportation and logistics for those individuals that have to come back for their second dose.
Awesome. Thank you, Christy. And then lastly, Jacinda, I know we learned a whole lot about what Loma Linda is doing. I don't know if you had any additional nuggets you had wanted to add to that before we get into our next question.
So yeah, once again, Dr. Jacinda Abdul Mutakabir. I'm an assistant professor at Loma Linda University, originally hailing from Detroit, however. Um, so in regard to vaccination efforts, I think that, pretty much the presentation explained what I've been involved in there. However, I would like to state that now we're in this place, and I'm sure you all can attest to this, where we are seeing just not the same amount of individuals that are enthusiastic about being vaccinated as we saw maybe in February, maybe in March, maybe in April. So we often find ourselves in this place where we have to recalibrate and figure out what is it that works. How do we continue to make sure that the individuals that need these vaccines are the ones that are receiving it, so that while we're seeing this decline in the COVID-19 vaccine infections, we are seeing an increase, in infections amongst minoritized individuals because they are the ones that are less often vaccinated. So now we've begun going into the community and knocking on the doors and going into their homes and vaccinating them. So we're ensuring that we can once again make equity a verb. So that's where we are right now, developing strike teams to go ahead and continue to vaccinate. So
Awesome. Thank you. Thank you. And I guess I should probably introduce myself here. Ado McGee. I am an assistant professor at Philadelphia College of Osteopathic Medicine, Georgia campus, School of Pharmacy. So I'll be moderating, and I'm excited to talk more to these ladies about how pharmacists have really led the efforts here in terms of the COVID vaccine. So thank you. My next question, what were some biggest hurdles in terms of implementation? So sort of, what has worked well and what maybe did not, that now you can look back um, and think through in terms of, like Jacinda, I'll ask you first. You talked about how you guys are sort of taking some lessons learned from what you've done to move forward. So you want to speak more on that?
absolutely, I can actually speak in terms of one particular situation. So the Johnson and Johnson pause, we began with really working hard to educate our minoritized individuals, so our Black and Latinx communities on the vaccines, really making them stakeholders in this information, providing webinars that included culturally representative individuals. So myself, our Assistant Vice President for Community Engagement, Dr. Juan Carlos Billiard, and Dr. Bridget Petit, who is a Black psychologist at Loma Linda. So we really worked hard to make sure that we could, have a culturally diverse group go ahead and deliver this information on the vaccines. So this was working well. However, that Johnson and Johnson pause kind of put us in a different situation where we now have to say, "Hey, remember all the phenomenal things that we told you about the vaccines? Well, we now have to talk to you about how the scientific process works. Sometimes, science has missteps. So let's talk about that too." But we had to be as enthusiastic with, as far as making individual stakeholders. We had to be as enthusiastic to give them the rocky information as we were when we gave them the great information. So that was very much a hurdle for us. It was a hurdle for me because when I heard the information, my heart dropped because we had been vaccinating so many individuals, and even me knowing just the risk, the low risk that's associated with the blood clots mentioned by Johnson and Johnson. I knew that we had been working hard to restore these trusting relationships. So I worried about where that would place us. However, what I did see was that by being honest and by being transparent and dedicated to really cultivating these relationships, it placed us in a different position. It placed us in that place where they then were individuals were more trusting of us because they knew that we weren't sugarcoating the situation. They knew that we were dedicated to giving them the information as it was, and not mincing our words or the circumstances. So that was very much a hurdle, but I think that that once again has showed us the importance of transparency as far as vaccines are concerned, and making sure that we maintain that. Another hurdle I would state would be, I guess, what I talked about is just seeing a lower uptake of vaccines. So the way that we are working around that is really trying to go deeper into the community and vaccinating, but also making sure that we educate communities around children being vaccinated, the necessity for children being vaccinated. And what's surprising is then when we talk to the kids, or when the kids come to the vaccine clinics, they bring their parents with them. And then when the parents see the kids get vaccinated, they're like, "Ah, I guess that didn't hurt. Let me go sit down, and I'll get vaccinated too because I saw my 12-year-old do it." So it's been very important, and it's been a very, very humbling experience.
I'd like to add to that too that um, just thinking about kind of the classic issues that come up with emergency response or your public health response is communication is a big barrier, and I was guilty of this. Sometimes you walk into a clinic and you're picking up another shift, or you're helping out, and there's not a good handoff of information, or things get lost in translation. So I forget sometimes of having kind of safety pauses and making sure You understand like what vaccine you're working with, what age groups, who are you screening, who you can let through, who you have to, the triage process, some of the logistics, and making sure that every volunteer that comes in knows the process and the steps and it's clear. So that sort of handoff of information is really important. I think one of the challenges too, and I won't speak too much on this, but some of the supplies that come your way, and they're changing every sort of day, different syringes, different, and working with those supplies can create some challenges that related to drawing up the doses and maybe dose errors. But I would say that's another barrier that was identified. I don't know if there's good answers to it, but kind of reminding people to communicate well and to be flexible.
Wow, very, very good points there. Any additional hurdles, Christy, you have to add to that? Definitely speaks to, pharmacists being one of the trusted professionals, and communication, right? That's a life skill for everyone. So very, very important. Any additional things you want to add on, Christy?
Yeah, so I think I forgot to mention that my background is infectious diseases clinical pharmacist. But so I've been helping out with the clinic now, and one of the biggest hurdles, and really continues to be really across the spectrum, I feel like, is what to do with extra doses at the end of the day. And I feel like this topic is relatable across probably every setting, no matter where you are. But even at the beginning, when patients had to make appointments and we tried to have the exact number of doses, prepare ahead of time, people didn't show up or they canceled, and that's just life. So we went from scrambling to find people in the hallway, on the patient care units, patients and families, people in the emergency room waiting areas, which, by the way, the search actually fell heavily on myself or the pharmacist that was closing at the end of the day, since we were the only clinic staff members actually affiliated with the hospital on many days. It's stressful. And I think, again, in any setting that you're in, I think this is just a really, really stressful process. So the tip that we've finally come to that I can just share is really all towards preparation beforehand. Number one, confirming the appointments just as best as possible. But of course, sometimes that falls through too. And then number two, taking advantage of places where there's a known group of potential people that might still need the vaccine. So for us, it actually ended up being our inpatient rehab facility, and coordinating that with the team to provide us with a list of patients that might be interested if we had extra. And how I can see this translating to, say, a more mobile type clinic is just looking to see if there's nearby businesses or group class type places like fitness classes, even schools now, since, right, we've expanded to include children now, reaching out to collaborate with them ahead of time to avoid really a stressful situation at the end of the day, if the goal, and hopefully it is still the goal for many places, to make the best possible attempt to avoid dose wastage.
Very good points. Very good points. Yeah, and one of the places I volunteer in, we are actually now at the stage of where sort of going neighborhood by neighborhood, in terms of just with the shift in demand, I guess. So yeah, definitely thinking of tips on how to get more folks to either answer their questions, or get the vaccine. Very good. Thank y'all. Another question I had. So talked about sort of what worked, what didn't. Of course, the forever changing dynamics of the COVID-19 pandemic, and now the vaccine with the change in demand. What additional tools were you able to use to sort of overcome some of the hurdles you mentioned, or just additional things that you feel like others may be able to benefit from potentially implementing at their site?
So I'll start with saying it's very much important to make sure that it's a collaborative experience. So the one thing that I feel that's made us successful with our clinics is the inclusion of every healthcare professional, honestly, that we have. So, at any point when I'm at a clinic, it is like, as I said, the pharmacists have a big role in vaccinating. We have a big role in kind of overseeing the vaccination process and overseeing the students. We have pretty much professional students that serve as our vaccinators because we like to make it a learning experience. But we also have physicians that are included. We have nurses that are included. We have physician assistants that are included, respiratory therapists, dentists. Our large vaccination clinic that we had was our operations was run by a dentist, Dr. Aaron Richards, and we really pulled all of our resources together to make these vaccinations our priority. And it requires all hands on deck. It requires for everyone to be able to go ahead and utilize the skills that they have there. We utilized our faith leaders. So we made this a community or an academic community relationship. We created a relationship there that we plan to leverage for other disease states. So I think that's really the largest key is being collaborative and really respecting the expertise that each professional that is included in this collaborative experience has, but also being with also acknowledging that it's okay, you know, to draw on your fellow professional to assist you with the process. I've made so many lifelong professional friends, you know, during the clinic efforts, and not only that, but our professional students being able to work together. So often I'll walk in, you know, and I'll see the pharmacy students and medicine students drawing vaccines together, and they're in conversation. They're like, "Oh, so this is what you learned in school." So, you know, this is what you learned during your first year. This is what I learned. So we start creating those collaborative experiences and those collaborative relationships, and kind of thinking through roles very early on. So once, you know, these students reach this pathway or reach that aspect where they are practicing, they're able to have, you know, these small experiences from these clinics in mind. So I think it's definitely multifold of the way that we have to think about the vaccine clinics, but keeping collaboration and multidisciplinary efforts at the forefront, I think is just very, very important.
I have just some quick little tidbits for my colleagues out there. I'd say be flexible. Sometimes pharmacists are a little bit rigid and we like process and order. When you help out with these situations, you have to be very flexible and encourage your patients who you're vaccinating to be flexible. As Jacinda mentioned, we have to talk to people about science. Things happen and they'll say, wait a second, you told me this. Now you're telling me this. So I let people know, stay flexible. I even tell them, do not laminate your vaccine cards. Take a picture because you might need boosters. We just don't know yet. And a lot of people will say, oh, yeah, I've heard something like that. Like, just stay flexible. Help with scheduling if you can for big groups. And I'll give you a quick example. Spokane decided to vaccinate a lot of our school staff and teachers on a Wednesday. Well, they quickly ran out of their substitute pool the next day. Some people were sick. So maybe Wednesday is not the best day to vaccinate a workforce that works Monday through Friday, but maybe Friday afternoon's a better day. So I think utilizing our clinical knowledge to help make better decisions. Keep up with the rumors, just so you're not caught off guard, because as you're working these clinics, you'll hear things and people don't want to hear like, I don't know what you're talking about. I haven't heard that. So it might mean to be on social media and be looking to see what is the chatter, what is the latest rumor, and have your responses prepared. As you can, I like to incorporate humor. So as appropriate, try to keep things fun and light. Levity can go a long way. But with that, recognize, especially as our age limits drop when we are mass vaccinating people, recognize those that are coming into the situation with anxiety. So we know kind of who to pair them up with and how to kind of handle them. Because we can do lots routine, take care of lots of people, but there's going to be always special exceptions that we need to handle with kid gloves. In the process of us hurry, vaccinate, we lose sight, I think, of counseling, the importance of that. And sometimes I'm a little bit slow in the process because I'm taking 45 seconds and telling them that their arm is going to be sore for a couple days and what to expect. And if they have a fever at that point, what to do, empower them with information, remind them the importance of those follow up doses. And also, this is our moment to showcase public health messaging. That's when we need to take 10 seconds and thank them for protecting themselves, their family, and their community. Give people a choice when they have a choice, because in this process, I think there's limited moments where someone feels like I have a choice in this situation, even if something as simple as they can pick which arm they're going to get vaccinated in. Give them a choice when they have a choice. And then finally, as pharmacists, as Jacinda showcased, her clinics are pretty much run predominantly. Pharmacy has a very, very active involvement, although she also showcased multidisciplinary collaboration is so important, and other members of the community. But I would say there's a lot of volunteers, a lot of people, whether they're young students or they're retirees coming out of practice. Pharmacists we're experts in this, and we should do QI checks throughout the whole process to make sure, is a deltoid actually getting injected in? And, just the process of vaccination. Are we taking a moment to counsel? Are we helping them through the process? Are we doing it correctly? So I would say those are probably my 10 points of words of wisdom to help us through this and future public health vaccination efforts.
Was awesome. Just following up, just a few things to add, I think, to your list. Being culturally sensitive is another one too. Something interesting that we encountered was when we're making appointments. There are some cultures where the order of the month and day is flipped. So, for example, May 4th to many of us would be 5/4, but in some cultures, this may come across as 4/5. So we actually, it was really eye opening. We came across a few patients that came in on the wrong day for their second doses. And so, really making sure that we communicate, like you said, appropriately, taking that 5 seconds to just confirm with them, hey, look on the back of your card. We're putting the date of your second appointment on here, and not really relying on the electronic communication that might get mixed up. And then the other thing to add on to this is, just in addition to being flexible, I'll just share an example where that we encountered on a day that we just had a lot of extra doses left. We had several days actually where this happens, and really having to get creative on the spot, maximizing the resources that we have on hand. We had to one day reach out to our colleagues in house, set up a makeshift vaccine clinic in the emergency room by the entrance, and really switched from having the nurses vaccinate to actually the pharmacists vaccinate, and running a whole mini clinic down there to use up all of our doses. But most importantly, take the opportunity to reach out to more of our community members to get them vaccinated.
Wow, they're awesome, awesome pointers there in terms of additional tools. I do have a question. Since Christy, you brought up in terms of just from a cultural competency standpoint, cultural humility. Any extra pointers in terms of the Be Safe and ensuring patients that maybe speak a different language were able to download the not an app, I'm calling it an app,
Yeah.
get get signed up to ensure that they have that follow up with Be Safe, or any additional pointers there from
Yeah.
anyone, Christy or anyone.
We actually, at the beginning, we definitely made sure to have extra people on hand, because there's a lot of people coming in. You have your little stations that you go to, you go get your vaccine, and then you have your waiting area. So in the waiting area, we would have one or two additional staff members just there with computers or um, notebooks on hand to help these patients go into the website, log in back then to register for their second appointments. Now it's actually automatic, but back before, you actually had to go in and set up your second appointment by yourself. There are a lot of times where the website was down, we had technical difficulties, and we had posters up, but definitely just ensuring that before these patients leave, especially if you're getting the Moderna or the the Pfizer vaccine, that these patients are set up to come back, and so that they know that they're not fully vaccinated until they receive the second dose.
Awesome. Thank you. Thank you. Anyone had anything additional thing to add there? Or?
So I actually ended up for the V-Safe because it is not very user friendly. It requires individuals to scan the QR code. We have especially in the earlier part of the vaccination process, where primarily are more seasoned individuals, were those being vaccinated initially. I would have to go myself and register them via VSafe, kind of walk them through that vaccination process, and will sign the vaccination process as it relates to VSafe. So them kind of logging in each day or responding to the text messages that they'll receive from the VSafe module. So that was a bit of a hassle, and the fact that it doesn't automatically translate for a lot of individuals. So say that they're Spanish speaking, and when they go into the VSafe does not appear in Spanish. I'm also not technologically savvy, so it was a bit harder for my individuals that were Spanish speaking to go ahead and register via that VSafe. So just being patient and being able to walk them through that. So I think that's another place. I think that Dr. Tariff did a really good job explaining that, of being flexible. So that was another area where I myself had to be flexible because, like I said, I don't love technology, but I wanted to be able to help them through that registration process. So VSafe is not easy to use. So if you can go ahead and help your patients with that, I advise doing so.
Yeah, no, very good point. Very good point. I don't know if you guys have any even pointers in terms of if you had patients that, like you said, if they get a response and they're not able to read it, were you able to have them be monitored a different way, and sort of out of the box thinking there that you're able to just ensure follow up? And like you said earlier, with that transparency of if they had any issues, was there like a hotline number that they can call in, or any of
Right.
any anything?
So we are sure to make sure that we include the number to both the Loma Linda Hospital, and then but we do also have community partners that are Spanish speaking, so that when we do go vaccinate in these Spanish speaking areas, or say we have someone that comes in to our vaccination clinic, we make sure to have individuals that do speak Spanish, because I'm in California. California is greater than 50% Spanish speaking. So we do have individuals on site there that are Spanish speaking. So thank God we end up having a lot of bilingual individuals there that are able to go ahead and assist us with the translation process. But if it comes down to us making sure that we keep track, or if they have an issue, they are able to connect with our community partners that are majority Spanish speaking.
Oh, that's great. And that's important. Talks kind of links back to that community partnership that is important. Very good. Very good. As we're almost wrapping up here, about just any additional tools, any comments, anyone wants to weigh in terms of just any additional tools you may have used, like additional incentives to help increase compliance with that second dose, or any additional tools as we wrap up here that you want to
Yeah,
share with colleagues?
I think something that I'm still actually running into is the number of patients that still sort of say don't completely understand that you should stick with the same vaccine that you received originally if you're going for a two-dose series. Because I've had a number of patients come back for a walk-in, saying that, oh, they got Moderna, but oh, we give Pfizer, so is that okay? I've also gotten questions, oh, just to help with accessibility, oh, I'm going to be out of town, but is it okay if I go, if I'm out of state? So say we're in Texas and they're traveling to California, is it okay if I get my second dose of whichever vaccine over there? And my response is always, that's fine, but you just have to make sure that you're aware of which vaccine you received first, and that where you're going is able to supply the one that you need. So that's something that I've encountered.
Very good. Very good. Thank you. Thank you. Thank you. All right, and we're just about here wrapping up. Thank you again, and of course, Colleen, I didn't know if you had one more thing to add on by chance.
No, I mean, as we're kind of wrapping up, but my brain went towards, Jacinda commented about this, that, initially people were coming to us in droves. They were clamoring for the vaccines. Now things have shifted and they're going to continue to shift. And I think the other thing we can do as pharmacists is to continue the dialogue, and ask in a non-judgmental way, kind of with a poker face, where getting at, what is holding you back. And I've been practicing that with some random people and people I know that are still not vaccinated, to help me better understand, and then trying kind of different ways to maybe have a breakthrough. And I've had some moments with complete strangers that I hope I convince them to get vaccinated. And I just want to encourage my colleagues to do that continuously, is ask the questions and try different kind of techniques to see if we can have a breakthrough for some of the more challenging groups, which are those that doesn't matter how convenient we make it for them, they're still not ready to get vaccinated. So that's a whole nother discussion for another day. But just want to encourage people to try, because maybe we'll convince one person, and then that's one person who's better protected and will prevent spreading it to others.
Yeah, very good. I agree. Thank you, Colleen. Any other parting words from the rest of our panelists as we close up? We definitely appreciate your time. So we hope this panel discussion was helpful to our colleagues as we continue to lead the efforts, because we want pharmacists to really be leading the efforts, because this is who we are. This is what we do, whether it's your personal circle or in your institution. So we want to ensure that we have tools from various perspectives and various parts of the countries that you just heard now, to give you tips and tricks, I guess, or extra tools that maybe you haven't thought of yet, to potentially add to your armamentarium of what you're already doing. So we want to thank you for your time and your attention. And thank you all to the panelists for their time too.